Give me just a second and we'll get the individuals on the line lined up and then we'll get started.
Surgeon to do a total operation.
I think we have anything down. All right, good afternoon. Thank you for your patience. Welcome to the Special Committee on Access to Quality Health Care. We have a couple of bills we're going to consider today. We're going to begin with Representative Crow. If you could check in to see if you can give us kind of an update on where we are. And then I know we had others. It looks like a few wanted to discuss both bills. So go ahead, if you don't mind.
So we're back again, House Bill 1403, operating off LC 338997. And I wanted to add just a couple of things. I know there's some other folks that wanted to speak yesterday that we're probably going to get to today that haven't had an opportunity yet. But before we got to that, I wanted to try to clear up a little bit of confusion. There's been some understanding or some concern that this would allow a new hospital to come in and be built across the street or in the same location or same community as an existing hospital, rural hospital. And that's not the case. That's not the intent anyway. The language in the bill may be a little bit confusing, and that's something we can certainly work on. But the idea is that the 55 hospitals that are part of the Georgia Heart program that are included in that this
Can
would
you explain real quickly to those in the audience what the HEART program is, or the way it's?
Yeah, so the Georgia Heart program is a state program where someone can donate funds to the hospital and get a tax exemption for their state taxes. It applies to rural hospitals that meet certain criteria. That criteria is laid out in the language of this bill. That's where the language comes from, is the identifying information that identifies those hospitals that are eligible for it. I think the confusion is really starting on line 11, paragraph 30A, when it talks about an acute care hospital established on or after July 1st, 2022 in a rural county. This is not to exempt a new hospital coming in to compete with one of those hospitals. This is to allow one of those 55 hospitals to be exempt from CON if they are doing a replacement or remodel or any kind of a large investment that would require a CON. And so to my mind, it would allow, hopefully increase the likelihood that some of these rural hospitals will get additional investment in them. If somebody can come in and invest to do an upgrade, an expansion, and not have to spend several $100,000 going through the CON process, then they may be more likely to invest that money in that project. But this is in no way intended or wanting to allow another hospital to come in and compete with those hospitals. This is trying to benefit those rural communities that have those hospitals. And in this case specifically that I was talking about would be Sylvan Grove Hospital in Jackson, which is our critical access hospital. And this would essentially be replacing, it would be a rebuild of that hospital. So it's not trying to compete with that, it's trying to upgrade that, build a new hospital to provide those services and some expanded services. And then lastly, to Chairman Knight's point yesterday, I know he had concern about Spalding Regional, and obviously Spalding Regional is not in my county, but it's very close. And my sister is currently in Spalding Regional Hospital with double pneumonia. She got right after my mom passed last week. So she's had a rough time, but she went to Sylvan Grove Hospital. They kept her there about 5 hours and then had to transfer her to Spalding. Fortunately, Spalding had bed availability. Otherwise, they would have had to send her to Atlanta Medical Center or Kennestone, which happened with my dad a couple of times last year. Great hospitals, but a long way from home. And so, you know, this is not, Wellstar has been a fantastic partner. I don't have any say in their business practices or what goes on with this new hospital and management agreements or anything like that. But I've told Brandon and Abigail and the folks from Wellstar, they're fantastic operators. Nothing would please me more than to have them continue to be the operator of the hospital in our community. But I don't have any involvement in that, but they have been fantastic. And I certainly want them to be able to continue that. On your desk there, you should have some language. It's one very small paragraph. And this would be something that I would consider or attaching as an amendment to it, to add another paragraph to more clearly define the exemption, that it only applied to the list of rural hospitals identified on the Georgia Heart Hospitals program as of December 31st, 2021, and also add a 24-month sunset on this amendment unless it was extended, to help, you know, cover some of the concerns that folks have expressed thus far. So that's something we'd be willing to look at. I certainly would be willing to look at.
And that's just, in your opinion, to double check any question there would be about this language. It narrows it down to simply those hospitals that are eligible for the rural hospital tax credit. Correct.
To really try to fix, I think, the confusion that's created by the language in the bill that you know, to help identify that, because most of the concerns I've heard are concerns that are not the intention of what my intention is with the bill. And I think it may have been some confusion with the language. So it would be a way to clear some of that up.
Just for clarification, we'll get questions from any committee members also. This is talking about moving the certificate of need from where it is now to a new replacement facility.
Yes, sir.
And are there representatives of the hospital that's going to be moved testifying on this bill, or that are proposed to be moved? Or you mentioned there'd been discussions, but certainly nothing formal from the hospital authority.
So Zach Sowell, the chairman of the Butts County Hospital Authority, was going to try to come yesterday. He's a local community banker in our community, and was unable to appear kind of short notice. And then today we knew we were coming back, but he had expected it to be yesterday and wasn't able to attend. But he has been involved in the discussions, and from everyone I've talked to with the hospital authority, they're excited to have a new hospital in the community.
And there's nothing in this that requires them to do that. Obviously, they still own the facility with the current certificate of need, and so without their permission or agreement, this would never happen. Your bill would allow it to happen, but it's still the choice of that.
Yes, sir. That's correct.
Hospital.
Yep.
All right, members of the committee. Chair Hatchett, did you? Oh, I'm sorry, Chairman Knight. Sorry.
To my friend, certainly familiar with this area, and I do have. I would be less than honest if I didn't say I had concerns.
Mm-hmm.
And I'm trying to understand some of the rules around the current CON. So my understanding is that according to the bill, it's an acute care hospital.
Mm-hmm.
And I guess my question is there are some current, I think under the rules, some current allowances for relocation of, if I'm reading right, skilled nursing facility, immediate care facility, micro-based hospital, the same county, or the healthcare facility in the rural county, the same county, within a 3-mile radius of the existing facility, as long as it does not propose to offer new or expanded clinical health services at the new location.
Mhm.
So I think what I want to be perfectly honest and upfront about my concerns. And that is, if I read the bill, it's a new hospital, expanded, all that. And certainly, as we discussed yesterday in this hearing, the hospital in Griffin, the Spalding County Regional, which is a Wellstar hospital, is approximately 12 miles away.
Yes, sir.
So I do have concerns there.
Mhm.
And I don't know what the discussions are with Wellstar. I'd be interested in hearing that, because if the plan is to build a huge new hospital out there, then while there may be great need in the future of this as growth comes, I seriously have concerns about what it would do to the existing facility in Griffin, where, is an existing hospital, surgeries. I mean, it may not be I think if you have some more specialty stuff or emergency, anybody, you go to Emory, Grady, Wellstar in Atlanta,
Mhm.
but and again, I don't know what grade, I'm showing my ignorance on the hospital, but it is a functioning hospital, surgeries and everything. So if you're building a new hospital, how is this going to interact? And my question is a couple of things. If it's Wellstar, where it's something worked out and it's, we've got a good healthcare system there, I'd be interested. But if this is going to be put out in a north side or Piedmont, and all of a sudden we're competing, we're at a point right now where we can't find enough doctors and nurses down there in that area. So I have some great concerns there as to how it would affect both of us if we're opening up a new facility, but a new facility here, and we've got an existing facility.
Mhm.
We're already stretched for physicians, nurses, and all that. So I do have some concerns. I'd like to hear either from you or Wellstar and others in regards to that, because I hope you understand my concerns.
I do. And I do understand your concerns. And like I said, as far as I'm concerned, Wellstar is a fantastic partner in our community. They've been great since they moved in the place of tenant. I don't think that it's my purview to discuss the business operators of that. I don't know that I have that latitude to do that. If they work that out, that's great, but I don't know that we're in a position to be able to do that. What I do know, though, is that right where this is proposed to be built, there's 8 million square feet of industrial space coming in a 1,600 acre development. Just this morning, I read an article in the Atlanta Business Chronicle that there's a proposed 383 acre development in Spalding County, just down 16 at High Falls Road, with another 2 million square feet, or I'm sorry, 4 million square feet proposed development right there where the new Griffin Spalding Airport is being built between Griffin and the interstate there. So you take that and all that we sell. Of course, I'm not as knowledgeable about hospital operations, but real estate, I do understand. And the amount of people moving out of the inner metro area to Pike County, Spalding County, Lamar County, Butts County is rapidly increasing. And so all of those folks right now go to Spalding for their primary needs. Sylvan Grove has to transfer to primarily Spalding usually. And so it would be 2 to 3 years before this facility even opened up. And I'm afraid if we wait much longer than that, the need's going to be there far before we're able to handle it. So I understand the concern, but that's my rationalization for it is it's coming very quickly. And I think if we don't do something now, it's going to be here far before we have the bed space available to take care of the folks in our community.
Well, just understand, I get the coming need, but if this doesn't forecast out or work out as, we forecast the growth, and all of a sudden there's 2 hospitals either both of them suffer at the same time or one of them suffers. I don't think either one of us would want that because we are so
We would
close
not.
together with our communities.
Yeah,
And
we
so
would
that is
not.
a concern. So it may be somebody from Wellstar, Mr. Chairman, may be.
I
able
think
to-
so. I do believe we have some signed up, and thank you if you want to just stay there. With the committee will allow. We'll go on and get.
Okay.
We do have some individuals from Wellstar. Leah,
Yeah.
just introduce yourself, and then
Mr. Chairman, I'm Leo Reichert, General Counsel at Wellstar Health System. I appreciate the opportunity to speak with you today. I speak in opposition to this bill. I want you to know Wellstar is not asking for this bill. And I also want you to know the hospital authority is not asking for this bill. We bought this hospital in 2015. Nobody told us there was a plan to move the hospital, build a newer hospital, relocate the hospital. Hasn't been on the drawing board, hasn't even been mentioned to us until some folks decided they wanted to do this. Now, I appreciate they're interested in doing it and support it if we can come to some sort of reasonable agreement on this. And if we can find a way that you can find an economically viable model to do it. But the hospital authority is not asking for this, and Wellstar is not asking for this. And the hospital community is not asking for this because it's not targeted. There are 55 hospitals that qualify for this heart fund. So there are 55 rural hospitals that can be moved around. And you pointed out, Representative Knight, the problem with this bill. You can pop it right over on a county line and you can impact not just your county, but another county. Spalding is another county that's over there. They can move this hospital right over there. And so we have to take into account what's going to happen in Spalding County. All those 55 hospitals are going to move like that. That's why this is not a targeted bill. It doesn't hit every county, but it hits 55 counties. The other thing I want to point out is what you heard yesterday about the CON laws and how they apply to this was wrong. So you pointed out a little bit earlier, you can move a rural hospital without getting a CON. You do not have to have a CON to move a rural hospital, period. Anywhere in the county, it's exempt from CON. That was done with the big reform in 2007, 2008. Used to be there was a mileage limit, and now you can move it anywhere in the county. So you don't need this bill to move a hospital in a county. You also have the ability to expand a rural hospital without having to meet need or adverse impact requirements if you get the county's support to do it. Wellstar did that in Paulding County. We didn't have a CON fight. We moved the hospital and expanded it. Northside did that in Cherokee County. They moved the hospital and they expanded it. No CON fights. That's how this is done.
so can I ask, so is your contention is that the current code, which is what I'm looking at as well, that says any other healthcare facility in a rural area can be moved within the same county. You contend that they can do what they're planning to do as long, obviously, if the hospital authority who owns the hospital wants to do it, it can be done today without this bill?
Yes, Mr. Chairman, Wellstar has done it. We moved the hospital in Paulding County from its old location to its new location in 2014.
Is it owned by a hospital authority or by
It was
what?
owned by a hospital authority. We have hospital relationships with 5 hospital authorities in addition to the Sylvan Grove one. So we have experience working with rural hospital authorities, and we moved the hospital exempt from, and we expanded it and went through the CON process for the expansion. But because the county supported it, you do not have to meet need. Now, I don't think there's an issue with need here because Mr. White House has mentioned that they've done a need analysis and believe there's a need anyway. But you also, unfortunately for Wellstar, but you don't even have to meet the adverse impact requirement. You can move it and you get a lot of flexibility to do that. And as I say, that's been done at least 2 times that I'm aware of and maybe more.
So if they decided to do this and started building this hospital, there'd be really no opposition, or opposition wouldn't matter?
That's correct. But one
Because
other
it's
thing to
allowed?
correct is we have a lease on the facility right now. So when we acquired Sylvan Grove, we got a 10-year lease on this facility, and that lease expires in 2025. So the hospital authority, I've heard, this slowed down, CON slowed down the hospital authority. The hospital authority actually can't do anything right now because it's leased the current facility to us. So it can't move until our lease is up, and we have to work through all that. And we're willing to do that. We would love to have some conversations. We want to improve healthcare. We feel like, and I appreciate what Representative Crowe said, we feel like we've been good partners there. We feel like we've been good partners in the Griffin community, and we'd like to find a way to make all this, work for the entire community. But this bill is not good for what's going on down there now. And it's not good for the state of Georgia, and it's not necessary.
Chairman Cooper.
But I find it incredible, Leo, that you actually just admitted that some of the changes that you fought so hard to stop when we revised CON have actually been to your hospital's benefit.
Well, I
Would you
appreciate-
like to thank me now for those? Since
Well, for
it
that
was a
change, I
near
would.
battle to death over them then?
That was a really larger bill and had a lot of things in it early on that we didn't agree to.
Yeah,
You know that.
right.
You know
Yeah,
that.
right. Yeah.
Chairman Houston.
I'm confused. I thought you said you bought the hospital.
No, ma'am.
Didn't you say you bought the
We
hospital?
bought
did.
Spalding. We have a lease for Sylvan Grove.
Okay, so you have a lease for Silver Grove.
That's
But,
correct.
You said, when you said you bought the hospital, I didn't know. I thought we were talking about the hospital in
No,
Jackson.
I apologize if I wasn't. clear.
Yeah, and I was not clear, and then you said you leased. Well, I understand, is the hospital there? The Department of Community Health, didn't they say they could accommodate a 300-bed hospital at some time?
That's not correct. So there are two kinds of need. One is there's a CON process for calculating need.
Yeah.
And if you look at that process, there's a larger, Mr. Whitehouse said he's done it. And I think he said yesterday, 250 or 300 beds. Now,
Well, so you think that hospital is sufficient to take care of the needs of the people in Jackson, Georgia?
what I was going to say is that
And-
there's a need methodology and then there's actual need.
Okay.
The hospital in Sylvan Grove is half empty. The hospital in Spalding is half empty. So building a hospital that's bigger than both of those combined is, you got to find. patients
Actually, I
to fill it
got
up.
to ask you a quick question. Just when the hospital is very small, a lot of times the patients that are local that would love to go to a larger facility there choose to go to Atlanta or Macon or some other larger facility just because it's empty as a 25-bed hospital. Doesn't necessarily automatically translate into, if you had a new high quality state-of-the-art hospital, a lot more people might stay in the area. I'm just,
No, you're absolutely right.
I've heard that
And
before.
I don't really feel like this is a place where I need to discuss or should discuss all of Wellstar's health planning, but we've looked at out-migration from the area. And that is those people who live in that service area and go outside for services. And we haven't, yet determined that the hospital, that's an appropriate site to build a new 100-bed hospital and also balance that need out with what you've got invested in Griffin. So, and the other thing, so people can differ about sites. We've heard about this site. Maybe it's a good site, maybe it's a bad site. It's in the middle of a 1,900-acre industrial area. Right now, there's not a single medical practice there. There's not a hospital there. There's not a pharmacy there. There's not a residential development there. So you can put a hospital in the middle of an industrial site in 2 years with 1,900 acres and 8 million square feet of industrial space without a pharmacy, without a doctor's office, without that sort of stuff. So we have not yet concluded that's the right place for the hospital.
Do you know if there's any kind of an early termination arrangement in that long-term lease, that 10-year lease? If the hospital wanted to move and pursue?
We are open. I talked to Mr. Jones after this and said, if you'd like to talk to us about all this, we're happy to get together and talk. We talk with the hospital authority all the time, the hospital authority in Butts County, the hospital authority in Griffin County. And as I say, we want to improve healthcare in those counties and do right by all those folks down there. Just has to be done in a sustainable way.
Thank you. No more questions for this presenter. Are there others that wanted to speak in particular toward Bill 1403? I know there's some that signed up to address both. Is hospital, how about Anna? Would you like to speak?
Thank you, Mr. Chairman, members of the committee. In the interest of time, because I know we do have another bill coming up, I would like to officially, for the record, have it be noted that GHA is opposed to this legislation. We represent more than 50 rural hospitals throughout the state of Georgia, those falling in that same category of receiving those Georgia Heart funds. And, I will say for the benefit of the committee that in 2019, you all passed House Bill 186, which was comprehensive certificate of need reform. And we agreed to those changes. Those changes were robust. And under those changes, I'd like it to be noted that those applying for a new facility, a certificate of need in rural counties, are exempt from CON filing fees. I know we've had the discussion here today about the cost. There are also new restrictions on who can appeal for a CON award. So it limits it to 35 miles radius. So some of the arguments here today, I think, may be based on prior to the 2019 CON changes. I'd just like to make that kind of part of the discussion as we move forward. You've heard from Wellstar about their wants and whether or not they'd like to do this type of purchase and move their facility. Leo noted you can move a facility now within the same county if it's a rural county. So for these reasons, we're opposed. We'll
Wait,
have,
you can move it now within
Yes.
the same county.
correct.
And you still oppose that? Or you just
No,
oppose?
we oppose the bill because we think you can already do that. And, had this organization applied for a CON and been denied, we might be having a different conversation, but that hasn't happened.
Any questions from the members?
You said we could
Chairman,
do this
yes.
now, they can do this now without a CON.
Yes, ma'am. In the same county, in a rural county, you can take a hospital that is already open with the CON and move it to another location in the same county.
And let me get this straight. You said you were for the changes we made in the CON. Y'all didn't fight us last time about that. Yeah, let's get it straight. I think we were both on the CON change thing.
Yes, ma'am.
Thank you.
I think you did come up with a bill that we finally agreed to.
Well, I think we could have passed it whether you agreed to or not. but
Yes,
Thank you very
ma'am.
much.
Well, we appreciate you considering our points.
Okay, thank you.
Chairman Cooper?
Haven't you figured out, especially Leo, that when you make women mad, we have long memories? And how we got handled during that process?
Thank you.
Thank you.
I don't know if there is anyone from Representative Crows or anyone who can speak to the issue that's been brought up, that maybe there's permission in the code to do this now, assuming you could either get out of your lease or have to wait till the end of it.
I don't know. Ed may be able to speak to that some, but I spent most of the morning reading through the code again.
It's exciting.
I know it was highlight of my day. And Anna and I had a conversation about that yesterday, and I think she is correct in saying that if we wanted to move the existing hospital, we could do that. But it's a 25-bed hospital. She said you can add some bed space. I think you can add 10 beds per year or 10%, whichever is greater. So that would put us at 45 beds
Which is
in
not-
2 years, which is still not enough. So there is some validity to what they're saying, but it doesn't apply in the case of what we're trying to do, a 45-bed hospital. And then they said you could build it bigger and then apply for the CON after that. Well, if you build 100 bed and you're only approved for 45, then that's a pretty big risk to take.
True.
And the thing about these rural hospitals that I do want to point out, one of the things that Leo said, that you are correct. They do not own the hospital. The hospital authority owns the hospital. They have a management agreement. We've been waiting for, like I said, this has been talked about for 20 years. And then it really got discussed a lot in 2012 when Ed was with Tenet and some things were going on back then. And then it kind of fell by the wayside again. There is not an abundance of people with the ability and the willingness to invest the kind of money it takes in a community like ours to build a medical facility. I think that's something that we've got an opportunity to do now. And there is not development right in that specific area right now. It is an undeveloped, for the most part, undeveloped interchange at I-75. The growth has come around it. There's been numerous homes and numerous developments built within 3 miles of that site. And just for one more point of clarification, when they built what's now Piedmont Henry Hospital in Stockbridge, there wasn't a lot up there either, other than a rock quarry and Eagles Landing developed around it. So I think there's a precedent for that to help the area develop. So.
Thank you, sir. So your bill, even though something that sounds like it's allowed, it would take you 10 years in bits and pieces, adding 10 beds a year, which is of course not a reasonable way to
Yes, sir.
build a hospital, especially a state-of-the-art hospital with centers of excellence for different needs. But it is permissible to do it now, but you would just have to do it in bits and pieces and slowly. But the second point, though, I believe is none of this can still happen. None of the moving of the CON or moving of the owner of the hospital, unless the hospital authority votes to do that, correct?
Correct. Yes, sir. That's
So nothing happens without the hospital authority agreeing to it.
correct. It would have to be a partnership with them because they hold the current certificate of need. So, and again, their negotiations, Wellstar's negotiations, or their lease or management agreement with the hospital authority. I'm not privy to any of that, but that's something I'm sure that they're aware of.
Chairman Knight.
Point of clarification, I think it was the counsel for Wellstar. So you have a lease in essence, or management arrangement contract with the Butts County?
It's a lease, yes.
Okay, and the terms of those lease or the remaining life of the lease?
It ends in 2025.
Okay. So if you were to do this, how would that affect your lease with Wellstar?
Are you asking, you looking at me? Or you
Well,
asking me?
or maybe both. I mean, I'm trying to understand that. So,
As I say, I don't believe that currently they could go through the process because we have the operational lease and the authority over the CON and all that. So to file a CON to move it would require Wellstar's agreement right now.
okay.
And just to clarify one question, you asked about expanding. I perhaps wasn't clear. Wellstar moved Paulding Hospital and more than doubled the size of it. Northside moved Cherokee Hospital and more than tripled the size of it. There's a process to go through to expand, to add new services, to add new capacity, to add new size. And you have exemptions from a number of the CON provisions to make it easier. So we did that. Nobody opposed us. Northside did it. Nobody opposed it. It's been done around the state, and it's for this very purpose today, to move and expand. Thank you.
Thank you. I believe there's, I guess, others that would like to speak to the bill. Please come on up and introduce yourself.
Mr. Chairman, good afternoon to you and the members of the committee. I am Julie Wyndham with Atrium Health. And two of my hospitals have been a part of this discussion over the last 2 days, so I thought I might address those issues if you wouldn't mind. Atrium Health has 2 large tertiary teaching and trauma facilities in Macon and Rome, but we also have 5 rural hospitals, all of which are Georgia Heart hospitals located in Polk, Baldwin, Putnam, Monroe, and Peach County. So I want to talk just briefly about Peach County and Monroe County, since questions have been asked about both of those. With regards to Peach County, we took advantage of this CON relocation provision in 2013. That hospital was built in 1953 as a Hill-Burton hospital, very similar to the situation that we're talking about here today in Butts County. The hospital was in Fort Valley. The growth area in that county was in Byron, close to 75, as Representative Bentley very well knows. And we did move that hospital and rebuild it. However, after hearing from the community, their request was that we keep that hospital a critical access hospital. So we did not expand at the request of the community. We did not add beds. We also were requested by the community to continue to serve the primary service area that the old hospital has served, and that's what we did. With regards to Monroe County, that's a hospital that was built in 1976. And is very close, Butts County. Sorry, that's kind of tongue twister there. They were built in they were built in 1976, and in 2016, Atrium Health entered into a management partnership with Monroe County Hospital. They are still owned by the hospital authority, but we do help them manage that hospital and operate it. And I just want to let you know how strongly that community supports their hospital. In 2017, the residents of Monroe County voted to raise their millage rate to keep that hospital from closing. In 2019, in partnership with Atrium Health, we invested $3.6 million in facility upgrades to that hospital, including removing asbestos from some of the hospital because it had not had any capital investment in so long. And then in 2021, through the Georgia Heart Program, the community donated $1.1 million through the Rural Tax Credit Program. So while we truly appreciate the sponsor's intent and appreciate all that he's done to work with us on this, we are concerned about the impact this would have on our hospital in Monroe. The most immediate impact would have is on our workforce. Monroe currently has a 36% vacancy rate in its staffing. If you build a new hospital near us and add 75 beds, where is that staff going to come from? It's going to come from the surrounding hospitals because we all know in Georgia, there is a workforce shortage. That is one of our biggest concerns about this. We also have some concerns about what happens to our critical access status if another hospital moves within 35 miles of us. Federal qualifications require that no other hospital be within 35 miles of a critical access hospital. And then just the general impact that this bill could possibly have on the 54 other counties other than Monroe, if someone chose to come in and simply build a hospital to compete with rural hospitals that are already there trying to serve their community. I just want you all to realize CON is not the reason hospitals are not operating in rural counties. It's you just can't make money off of them. It's the market forces that keep people from opening new hospitals. Those of us that are there because it's our mission to serve those hospitals, serve those patients, and serve that community. So just please keep that in mind as you consider this important legislation. Thank you.
Thank you. Come on up, just introduce yourself and.
Mr. Chairman, thank
Yes,
you,
sir.
and thank you, ladies and gentlemen of the committee. I come to you today as president of the Georgia Alliance of Community Hospitals, representing 92 not-for-profit hospitals across the state, both urban, rural. I have had conversations with the author of the bill. He knows our position. I know what he's attempting to do. However, it would have statewide implications. We currently have a situation now in South Georgia where a hospital, they're trying to build a new hospital on a county line. That would be Lee County versus Dougherty County. Dougherty County being the larger county. This hospital, as proposed, would be 1.5 miles from the emergency room at Phoebe Putney Hospital, who are losing $12 million a month now. And this would take a lot of their paying patients over. So it does have statewide implications. I have been meeting with the parties since, the end of last session. Mr. Jones, who I admire and kind of a mentor of mine, he and I were elected the same year together to serve in the House. And I think we got out the same year, but I have a lot of admiration for him and I know what he would like to do. And I would like for us to continue negotiate with Wellstar to resolve this issue. It can be done, and I think it will be done. But as others have said, you can already move an existing facility anywhere in that county. And as Leo mentioned, there are exceptions to CON where you could add beds. And if you don't mind, I'd like to momentarily just introduce Kathy Palvino, who does a lot of CON work and serves as our general counsel. Thank you.
Certainly.
Thank you for your time, and I will make it brief, given the
Thank you.
comments that have happened to date. But I just wanted to, before we got started, I was speaking with Representative Crow because the opposition to this bill is not necessarily what they're trying to do in Butts County, but it's the broader implications of deregulating in rural areas where we also already have instability. We already have hospitals operating in the red. We already have staffing shortages. I'm not going to talk about those again, but that's our concern with this bill. I'm here to also say that there is a path forward, and I've spoken to Representative Crow about it briefly, and we'll be happy to continue to do it today. So there's discussions. I worked with Northside Hospital Cherokee in terms of building that replacement hospital under an exemption and then adding beds incrementally as they were needed. And they continue to do that. And it's a beautiful facility that's meeting the needs of the public. There's also ways to do it immediately. If a hospital wanted to, it's been said, and it's true, you could relocate a rural hospital anywhere in the county, but you can't expand clinical health services. So that means you are confined to that same number of beds until you can show there's a need for more beds. And when you can show there's a need for more beds by operating at higher utilization levels, you can continue to build. You can also replace a hospital and have observation beds, which can then be converted to inpatient beds. And that's another model that hospitals use all the time to build out a facility to meet future needs. Also, currently, a hospital, if they wanted to build a bigger replacement hospital and do it without having to go prove a need, they could do it if the county committed 20% of the capital cost of the project. And it doesn't have to be county funding. It could be development authority bonds. It's essentially, there's a CON loop exception if a community believes there's a need for a bigger hospital. And that is how a lot of hospitals have replaced to larger size facilities than they were initially. That could happen today if you had a development authority willing to sponsor projects. So I'm just here to say there's a lot of ways this could be done today without the need for an exemption that could cause unintended consequences for the very hospitals and the very communities that you're trying to protect. Thank you.
Did you say you think it's the only way they could do it is if they do the piecemeal approach?
No, there's two ways to do it. One is you replace with an exemption, and then you add beds as under additional exemptions as they're shown that you're filling up beds. I mean, essentially the standard to add additional beds is that you're filling up the beds. The other way to do it is right now today, if the county was willing to finance 20% of the capital cost of the project, then they could do that project today at a larger size. So there's two avenues and ways to pursue what they're seeking to do. It just requires obviously cooperation with the county governing body, county development authority, as well as the local hospital. But there is a means to do this today without the need for this legislation, without a piecemeal approach.
Thank you. Mr. Veazey, if you could step back up, Chairman Cooper.
Yes, ma'am.
Yes, Monty, that little hospital and that building that you're saying you have a problem with down in Albany, is Phoebe Putney still the most expensive hospital in the country to attend, like it was for so many years, where they had the highest charges in the United States? Is it still there? And their charges would maybe a new hospital going somewhere, maybe want to give people a choice and not go into some place where they get ripped off?
I don't think that to be the case, and I don't think they're the highest cost provider.
Still, they were.
While they do have a disproportionate share of indigent and uninsured because they serve 27 counties, all rural in South Georgia. We have the highest Medicaid rate. We have the highest uninsured population. And as you know, the insured patient pays part of the cost. So that would be a reason for it being higher than, I guess, any other, as you say.
Okay, they were, and it was national figures, the highest charge in the whole country. And one of the reasons that industry would not come back into that county again for many, many years. And they also, forced the closure of another hospital and all. They weren't really someone that played nice in the same manner. So I just wondered if they were still continuing to do that, which might have made people want another hospital in the area.
Well, I thank you for those comments. I do not know their charges,
Got a couple of other questions.
Okay.
but
Thank
we
you.
could find out,
Okay.
and I'll be glad to.
Motivating factor for another hospital, wanting to be in the area because of what it was like and what all had gone on. I owned a home there. So, was aware, and it's something we talked about for years, about the fact that the whatever brewery was there wouldn't expand, and the companies wouldn't expand down there because it was the highest employment cost, and they wouldn't bring industry into the area.
I'll
Thank
be
you.
glad to
Thank
try to
thank
get
you.
you. the
Chairman
charges.
Heston.
Thank you.
Thank you.
When you mentioned Phoebe, did they still have accounts in the
Cayman
Cayman
Islands.
Islands?
I'm sorry.
Cayman Islands.
Did they still have accounts?
Well, I'll address that. When we do captives, Cayman's was the only place you could do them. Now
Now you can do them in Georgia. I mean, in South Carolina.
Now you can do them in South Carolina, and some have moved to South Carolina. The only reason we have captives to begin with is to insure our physicians. With malpractice, that market going out, we insure our physicians through those captives.
Well, and being from South Georgia, I remember when you had Phoebe factoids and some of the things that came out. And I don't blame the people in Lee County for wanting a hospital.
Thank you.
Thank you.
Patrick.
Thank you, Mr. Chair. Mr. Veazey, I don't have a question about Phoebe Putney at all. I'm sorry. But I just got to ask this question. I don't know if I heard you correct or not. Did you say that on this issue, you were hoping that we could wait a little bit and let private enterprise and the hospital that's leasing it try to work things out?
Well, no, and you don't have to do that. I'm suggesting, though, that negotiations have been taking place with Mr. Jones and Mr. Whitehouse. I hope and I encourage both parties to continue those negotiations and maybe have a solution to this entire issue. That would be my preference.
So if CON wasn't involved, they probably would already had something worked out, wouldn't they?
If what now?
Nothing. I'll be
I'm
quiet.
sorry.
Mr. Chairman, at the appropriate time, I'd like to make a motion.
We got a couple more committee member
Okay.
questions and I'll recognize you for that.
Mr. Chairman,
Chairman Parrish.
and maybe the gentleman who's the attorney that spoke a little earlier, this bill is proposed, I think I understood it, that this would have statewide implications. And if you're one of those 50 counties or whatever that has a heart hospital in there, that someone could go in and build a hospital in that county without a certificate of need if this bill passes. Is
I
that
think
correct?
They're suggesting an amendment to it so that you could only move one, that it would affect all 55 heart hospitals subject to the amendment. And the current language is not clear. And so under the current language, it would seem like you might be able to do that if they clarify the language so it only applies to an existing facility. Then it would only apply to an existing facility. Now it's very vague and could potentially allow a new one.
But if there is an existing hospital in that county now, and I decided I wanted to go build another hospital in that county, under this, I'd be able to do it, right?
That's correct, as drafted.
No.
As drafted.
I believe it's only.
I'm getting a
only,
yes and a no, Mr. Chairman.
It's only one that's already been established, or it's already part of the, no, you're right, that's part of the amendment.
That is
it's
part of the
only
amendment, and
To clarify
you're
that.
getting a yes and a no because there's a bit of a disagreement on the interpretation of the way it's currently written. That's not the intent of the way it's currently written, and that's not my interpretation of it, but some others have. That's why I was offering the amendment that had been placed on your desk up there to clarify that. So there would be no question about that. Mr. Chairman, if I may add real quick, we did have discussions about the Development Authority and their ability to the 20%.
Right.
I currently still am a member of the Butts County Development Authority, and our community has not the appetite or the ability to fund 20% of the hospital or take on those kind of obligations, bonding obligations. And so that wouldn't be an option for us.
And once again, just to make sure I'm understanding this, if this amendment in particular that says it's one of the heart hospitals, the only way is if the community was just as passionate as some of the communities that were described, and they voted to that, the owner of the hospital, along with any other agreements they might have. If they wanted to move their certificate of need, they can do it. No one else can come in from the outside and just be exempt from CON. Only the hospital authority. Most of these are older Hillburton hospitals.
Yes, sir. That's correct.
Okay. Chairman Knight. I'm sorry.
Mr. Chairman, I don't know if lead counsel or one lead counsel out there could help me understand this, but on line 33B, in the event that in the county in which an acute care hospital established in accordance with this paragraph is located no longer meets the definition of a rural county, after such hospital has commenced operations, the hospital shall be deemed to continue to meet the requirements of this paragraph for as long as such hospital continues to operate. I guess my question is, going back to yesterday, acute care hospital, that's what it currently is. So could I get a contrast or compare that to whether it's hospital in Stockbridge or our Wellstar and Griffin as to the different type of a hospital? Are all of those hospitals acute care hospitals? Okay.
I think our hospital at Sylvan Grove, I think Mr. Whitehouse identified it as a subacute care hospital. So
That's not accurate. It's an acute care facility.
is it? Okay. And I don't,
Thank you.
Full disclosure, I don't know the difference.
let's see, did Representative Bentley?
Thank you, Mr. Chairman. I apologize for my tardiness. I was on the Ways and Means Committee meeting, but I know a lot has been said and I know we are pressed for time, so I want to move on, but I just want to be clear. Yesterday, I know there was a lot of questions about the Development Authority. You kind of touched on that a little just now. And Wellstar, I need to be clear on what is Wellstar's full position on this and the Development Authority for Butts County.
Well, the Development Authority, that was mentioned as part of us as the county governing structure, being able to fund 20% of it and be exempt. And that was a separate discussion. I think you're talking about the Hospital Authority. Their position, the members of the Hospital Authority that I have talked to, which is most of them, are in favor of this. They have an agreement, a management agreement with Wellstar for Wellstar to manage that hospital. The Butts County Hospital Authority owns Sylvan Grove Hospital. They have a management agreement with Wellstar, and I can't speak to the terms of that agreement. I know their council has said that it was through 2025, that management agreement. I don't know what options there are for them to have an early termination of that agreement or anything else. But the Hospital Authority, who owns the hospital, is in favor of and would be in support of, from discussions I've had, a new hospital being built in our community.
Okay, and lastly, Mr. Chairman, if I may, just a quick follow-up. Representative Crowe, without this legislation, what would this really mean for the citizens of Butts County?
Well, that's an opinion-based question, so I'm going to give you my opinion for what it's worth. And from what I've seen over the past many years, this has been talked about, like I said, for probably 20 years in our community. I think that it would be many, many more years before we were able to get a new hospital done because of the cost and the time that this adds. Even if we did go through the CON process, it would delay us several years and cost a lot of money to get that done. And I don't think we have time to wait for that. And from a layman's perspective, my wife and my sister were both firefighters and EMTs and worked for the fire department in Butts County. I know of hundreds and thousands of trips of people being transported to Sylvan Grove Hospital. Nearly every one that needed any other services other than maybe a bag of IV fluids got transferred out to another hospital, often all over the metro Atlanta area. We can't continue to do that with our growth. That's not feasible for us. I think it's a more immediate need, and I think that need is going to grow because of the growth in our area.
Okay, thank you.
Thank you. And thank you for the vigorous participation. I appreciate your effort on behalf of the citizens of your county and those I know all. We really care about rural Georgia. We actually have a commission we're trying to get passed to look even more into it. But I know sometimes you mentioned this has been going on 15 or 20 years already, or at least several years. I know at some point there's an effort to try to go on and get started. What is the will of the committee?
Motion to pass.
We have a motion to pass. Is there a second? There's a second. Motion to pass and a second. Is there any other discussion from the committee? We do have go ahead.
Mr. Chairman, I just, again, out of great concern, I just want to make sure I'm on the record. We've got great concerns about this because of the existing Spalding County, Wellstar Hospital. It's 12 miles away. Again, the issue of, nurses that we're trying to fill positions, physicians that we're trying to recruit into the area, that we're already at an issue. And I fear that this could end up hurting one or both of the hospitals. And I respectfully, especially my colleague and my friends from Butts County, I hope you'll understand my concerns for this, but I'm got grave concerns about this.
I understand.
Thank you, Chairman. We do have an amendment that's on everyone's desks that I'll put in the record. Betsy, do you have this amendment? Okay. See, it says should have been available for people. The exemption provided for in this amendment shall only apply to the list of rural hospitals identified on Georgia's Heart Hospital Program as of December 31st, 2021, and unless extended, this amendment shall stand repealed 24 months from the effective date thereof. It's a subsection C. Is that adequate for us, Betsy?
Well, I've got a couple of questions. Is the 24 months repeal intended to be this language or for the whole bill?
For the,
Not just for paragraph C, it would be for the whole bill, Yeah. Which would be paragraph or 30A.
And the second thing is on line 11, you have to either strike that date. There's no way if you add this amendment, then there literally would be nothing that would be apply that because no hospital can be in existence in December and also be established after.
Right. Line 11 is where I have the most concern about there being confusion. So if you have a suggestion, I would be happy to
Betsy.
hear that.
Can you come to a microphone? Thank you. We do have Dean Smyrie that had a question, I believe. Dean Smyrie?
Yeah, can you hear me, Mr. Chairman?
Yes, sir.
I've been around here a while, and I've seen certificate of need for a long time. I was here when we passed certificate of need, and remember the architects of it. And I mean, I have some concerns that we're doing this at this time. I think there's good chance to have some dialogue on issues of this magnitude. But you know, two or 3 days from crossover, I just don't think is the appropriate time. So I just wanted to say, you know, I haven't had a chance to vet this, but I do know the substance of the issue of certificate of need, and I think in some areas it may be good, and then I think other areas it may be harmful. So I wish we would kind of be a little more cautious about that. And so that's my hesitancy, and Mr. Chairman, I want to make that known publicly.
Thank you, sir. Betsy, can you give us the wording and the lines that would be changed to affect what's on our desks?
A suggestion on line 11, instead of saying established on or after, saying established as of December 31st, 2021 to track the proposed amendment language.
Well, we've got to get the Heart Hospital Program in there.
Right. And then the amendment language I would change to say this paragraph shall only apply to the list of rural hospitals identified in the Georgia Heart Hospitals Program as of December 31st, 2021, and then period, and then say this paragraph shall stand repealed 24 months after the effective date.
All right. Do committee members have any question about the amendment that's proposed? Is there a motion for the amendment? So I have a motion. Do we have a second for the amendment? Second. We have a motion and a second on the amendment. Let's vote now on the amendment. All in favor of the amendment as stated by Betsy, say aye. All opposed, no. Well, let's do this by raising hands. Everybody in favor of the amendment, raise your right hand. All right. Online is nobody voted. Anyone opposed to the amendment?
No.
All right. The amendment fails. We have a motion and a second. Majority Whip Hatchett.
Mr. Chairman, is it appropriate to withdraw my motion and table the bill?
There's a motion to table the bill.
Okay.
All in favor of tabling the bill, say aye.
Aye.
Any opposed to tabling the bill, say no. The bill is tabled and currently without the amendment. Thank you for your work, sir. All right, we do have an additional bill small bill to take up. House Bill 1547. Thanks for being with us, sir. You want to give us your bill and LC number? And
Thank you, Mr. Chairman. Bill is House Bill 1547. It's LC 33972. It's a 30, as y'all know, it's a 39-page bill. A lot of it is dealing with the repeal of CON in 2 years and replacement with a licensing program that still keeps indigent care requirements in place. If the chair would, I could briefly go through the summary of the bill, which is, y'all all have a copy. It's got the blue line at the top. And I'll just go through it pretty quick. The first into several parts have to do with ambulatory surgical centers and bringing their indigent care requirements up to 5%, takes away their requirement to have to provide Medicaid and Medicare. It also makes it so, changes the definition from single specialty ambulatory surgical center to physician-owned surgery center, and removes requirement relating to a single specialty. That's through section 1.4, pretty much does that for all those different surgery centers. Section 1.5 provides that a challenge to a CON appeal, that the applicant, if they win, they are eligible to receive attorney's fees to cover the cost of that. Section 1.6 is language about joint venture ASCs, which I have had discussions with the hospital association if that really changes what's currently occurring, and if that's so, then I don't have I guess we're in agreement there. Section 1.8, lines 298 through 321 provides that affiliates and subsidiaries of hospital authorities are subject to open records laws. Section 1.10, which is on line 360, it's addressing how much reserves a nonprofit hospital can have. And the proposed is 12 months operating cost as based on the Form 990 that they all file as nonprofits. Section 1.13 deals with the filing of the community benefit report and changes it that excludes Medicare and Medicaid losses from their community, cannot be included in their community benefit. There's some other little changes here. Section 1.16 is creation of a new mental health assistance program. It would be a program that would be subject to being funded by the Appropriation Act, but it'd be for individuals that are not insurable, don't have Medicaid, Medicare, or Peach Care. It would be a way for them to apply for assistance to pay for mental health issues so they don't have to go bankrupt. And it would be something that we'd have to develop further, but it just creates that program. 117 states that CSBs cannot provide, they have to prioritize their services for uninsured and Medicaid recipients over insured consumers. We have an issue where they are wanting to, of course, have more insured customers, but we as a state fund them and for the purpose of providing mental health services for those that are uninsured and on Medicaid. And because of that, we don't have beds for these patients to go to. So this is just hopefully trying to clear up some issues there. All of section 2 and section 3 have to do with the repeal of CON. Would make that effective in 2 years. Would make the other parts of this bill, the first section 1 would be effective January 1st of 2023. If you allow me just to make this statement before I get questions, Mr. Chairman, I'd appreciate it. You know, this involves both these bills today, and we've heard a lot, and we may know where the vote is headed by the previous bill, but certificate of need is, we call it CON or CON. What an acronym, CON. Well, I would agree that this is a con game gone awry. We've allowed our large hospitals to become monopolies on their communities and continue to raise prices and the cost of having procedures and care take place in their hospitals. What's con allowed them to do? The large hospitals get larger and our small hospitals continue to struggle to survive. Why? Because the big guys recruit providers like doctors and nurses with their large payroll power, and the little guys can't compete. For example, one of the large hospitals was recently paying their RNs $8,500 to recruit an RN friend to come to their hospital, and the RN, when they came, got an $8,500 signing bonus. How's the little guy survive? The big hospitals entice physicians. We'll triple your pay. It could be a surgeon in a small hospital. Maybe the only surgeon that hospital has. What's that do? It wipes out the hospital if they don't have surgery going on. But the bigger guys cry, don't get rid of con. It's a never-ending cycle, and it's a slow takeover of our entire statewide hospital system. Our nonprofit hospitals are owned by their communities. The definition of their varies at each hospital. We've got several in this state that I consider their community is the whole state. And we got some that are huge regions of this state. That's their community. Con raises costs, it stifles competition, and it is not free enterprise. I hope you'll walk with me and try to correct the path of our hospital system from being controlled by a state licensed monopolistic hospital system. And let's invite competition and reduce our healthcare costs. Thank you.
Thanks, sir. Are there questions for the presenter from the committee? Number 12.
Thank you, Mr. Chairman. Mr. Whip,
Don't whip me
you made
too
a
bad.
statement I would like to ask about. You said that if these larger hospitals recruit that surgeon out of a smaller hospital, it hurts it.
Correct.
But you would let a freestanding surgery center develop without a CON right next door to it, perform the surgeries that they would perform at that hospital, and let the hospital go down when that hospital is going to be open 24/7, 7 days a week, and that surgery center is going to be open 9 to 5, Monday through Friday. Is that correct on the CON?
I would say you're right. I mean, a surgery center could do that. I would argue that if that's the only surgeon in that city at that hospital, the surgery center is probably not going to be there because there's not enough business for them to do it. That would be my argument.
Chairman Parrish.
Thank you, Mr. Chairman. To my friend, the whip there, I agree that we need to take a long, hard look at CON. And I think there's some changes that probably need to be made. Many of you on this committee have studied this issue much longer than I have and know much more about it. But I don't think the answer to the CON issue is to totally eliminate it. I think that the answer to that is to specifically look at changes that we need to make that would make healthcare better in this state. One of the issues that came up in the previous discussion was the amount of money that was required when somebody made a CON application. And I think about the issue over in the Columbia County, Augusta area, where they were trying to build a new hospital over there. Now, really, this goes back several years, but they won the certificate of need, but then were sued. So it goes up through the court system and they win the appeal. Then it's appealed to another court system. And so the only people that came out ahead of that were the attorneys. And that hospital, Mr. Chairman, has been delayed 5 years, 7 years, however many years. And that's ridiculous for something like that to happen. The amount of money that it adds to the expense of healthcare is ridiculous. That's the kind of things we need to look at in the changes that need to be made in CON.
And I would be open to work with you on doing just that.
You got it.
Representative Fry.
Thank you, Mr. Chair. Ms. Whip, you know, we've gone, you and I have gone round and round on this issue over the past handful of years. And I'm kind of torn when I'm saying this. I'm speaking to the audience as well. You know, I think we wouldn't even have this conversation if we had filled the gaps in our Medicaid coverage when we had the opportunity. But then I am torn in supporting this idea because I know we have some rural issues, rural healthcare issues. And I feel like the clock's ticking on the folks that provide healthcare in this state, because it's about to run out and we might be faced with a situation where we need to do this, a bill like the WHIP's bill, or we need to talk about other ways to get rural healthcare kickstarted, because I've only been here a decade and I'm about tired of hearing everybody talk about how people in the rural areas aren't getting healthcare, because all we're doing is talking about it. And I don't see the hospitals making moves and I don't see this legislature making moves, except for we're just going around in circles chasing our tail. So, Mr. Whip, I'm here to tell you that without some good support on any other alternatives, that I feel pretty good about this right now.
Thank you.
Based on to correct my position in the past, because we have not gotten the support for the rural areas that we need from the people in this room.
Thank
you. Chairman Cooper.
One of the things from the last meeting was about the big hospitals. One of the problems that we have with rural hospitals is that because they are small, they often cannot offer the kind of care people need on a continuous basis. That would be like for cancer patients, where they have to drive to Atlanta to go to one of the big cancer hospitals, or to the, to Savannah or Columbus, where our smaller hospitals could use, even if they come to the bigger hospitals, could be treated in their home communities to help them support their home hospital, if they were helped and allowed to do this. So one of the problems is that, everybody thinks that if you have cancer or a real complicated heart issue, you have to go to the big city, to the big experts. And it's one of the problems with having the big monopolies, and not going to the Emory Winship Center and all. But the other thing is, we did try in that very first CON revision, remember, Penny? We did try to end all of the process of fighting over whether somebody should get a CON. And once they got it and challenging it, we put an end at it, or we're trying to put an end in that process once it had gone through the state and one round, I think it was, in the court system. And we couldn't get that in. I know how you feel about it, because you're drawn to just wipe it out, because anytime you try to make even minor changes, the answer is always a room full of lobbyists in the hospital, and the answer is no. And even when they will tell you in private, oh yeah, that doesn't really affect us, but we just can't open up CON. And yet they came to me one time to open up CON for something they needed. I gave them my word that I would not do anything but what they wanted without coming and talking to them if somebody wanted to change it. That happened in the process. I went to them and said, this doesn't relate to you. Could we do this? The hospital said, oh, no. And I said, fine, I gave you my word. We changed what the hospital wanted, or what the hospitals wanted. And that was okay with them to open up CON then. But if it's for anybody else, the answer is no. And I think that's the frustration that all of us are feeling. I mean, because we've seen it when we make some changes, we've helped the system. But the fight is so freaking bad against everybody that says no and hires 80-something lobbyists and not paying attention what is good for the overall people of the state of Georgia. That's why we're back here doing it. And I really think someday the legislature is, like Fry says, is going to reach the boiling point, if something's not done, where we do wipe it out. And, I'm not really for that. I can see both sides of it. I've been in this fight so long. But instead of a cooperation and trying to find answers that we see to our rural areas and other procedures, it's just no and no participation. And personally, I'm sort of like Matt. I'm sick of it. And everybody thinks, oh, you're terrible. You're terrible. You don't like the hospitals. That's not it. It's just that maybe we're not getting paid by the hospital. As a lobbyist or a hospital lawyer like Leo, we're getting paid very little to look at what's best for the people of Georgia. And I'm just sort of sick of it. A total revision and wiping it out is not what I would see as maybe the best way. I differ a little bit with my whip on that, but I can see how you reach that point and the frustration level.
Thank you, Madam Chair.
Yeah.
I know, as Chairman Parrish had mentioned, the 5 years that some counties have been waiting on a hospital with the CON process does start to make you think maybe the only solution is to start from scratch. Chairman Nix.
Yes, thank you. I'd just like the chair lady to know that I support my local hospital, and I am not being paid at all by anybody in the hospital business. Thank you.
No more questions at this time, sir. We have others that wish to speak on the bill. Let's see, Dr. Chris Walsh. is online. If you could, there you go.
Yes, sir.
Please just introduce yourself and then proceed.
Thank you for letting me speak today. My name is Chris Walsh. I'm an orthopedic surgeon. I practice south of Atlanta. I've been in practice in Georgia for almost 20 years and have been part of a physician-owned surgery center for about 18 of those. I am on the board of the Georgia Society for Ambulatory Surgery Centers, and I'm a past president of that organization. We represent approximately 3,300 ASCs, or physician-owned centers, across the state. They're throughout the metro area, but also in many rural areas and small towns. In most cases, they are owned and operated by a single or small group of doctors. And as you know, currently that is within a single specialty and even a single one entity group. I think they've been excellent for healthcare access and quality of care in Georgia over these years since the LNR statute was introduced. They've been providing high quality care in any study that you can look at, patient satisfaction, and cost savings for patients and the system as a whole. Some of the things that I urge you to consider in this bill that affect the centers include the opportunity to perhaps have more than one specialty at a given center, particularly in rural areas where these centers are often underused because a physician may operate 1 or 2 days a week and is in the office or at the hospital other days. Also allowing perhaps multiple groups to participate in one of those centers would help in those areas as well. In considering the indigent care provisions, I would urge you to consider a few issues. Those are currently in place, and the centers do participate on that level now. The ESCs are also taxed, unlike many of the hospitals. We also receive, based on the Medicare rates, which trickle down to private insurers, about 50% of the reimbursement of hospital outpatient departments. Centers now, particularly the smaller ones, are starting to feel the pressure, or have been for some time, the pressure of inflation, as mentioned before by Mr. Hatchett, staff salaries, and in addition, supply costs go up, implant costs go up. Other types of businesses can perhaps adjust their prices to reflect that. Certainly in healthcare, that's a different issue. So we are seeing centers now, particularly the smaller ones, that feel the pressure to either close because they just can't make it or become acquired by a system, which then, of course, defeats the purpose of this avenue for lower cost, high quality care. Thank you.
Thank you for being with us today. Any questions for this presenter? I see none. I know we have several who signed up to speak to both bills today, that both regard CON of the first two. There were some who signed up that did not have or did not speak. Victor Moldovan, are you here? I don't think you. Please go ahead and try to, if you can be a little brief with us, so the committee's time is challenged.
Of the bill. As you know, I've been down here working for a long time. Good to see everyone. On behalf of physicians and physician-owned centers and free enterprise in the healthcare industry, we support as much flexibility as can be obtained for operations in the state of Georgia. I think the bill in this case is sort of the final straw, I think, for a lot of folks who deal with CON. That's the only way to get the attention of the committee and of the legislature is to repeal CON. Effectively, we know that every federal administration from Reagan forward, Democrat or Republican, has asked each state to repeal CON. We know that the 3 largest states in the country don't have CON: California, Texas, Florida. Florida repealed their CON law a few years ago, except for hospice and maybe nursing homes. So you've got these massive states who have no CON. You can build hospitals, surgery centers, and the communities decide what they need. And then private enterprise or hospital authorities or government builds what they need. Effectively, that's what should be done in Georgia. So we fully support the bill in this case. We support the repeal. I would note that the problems that you guys have tried to address over the years in terms of cost and delay have not gone away. I had a client who wanted to build a small imaging center in Thomasville. It's taken 2 years. Now, some of that's COVID related because of delays. It cost them probably $300,000 or $400,000 to build an imaging center with 1 MRI because the local hospital fought it and still fights it. The only options for folks in Thomasville for imaging was to go to their local hospital or go to Tallahassee. And that's what they did. We have a lot of folks who went to Tallahassee because the cost was too high. So our client took it upon themselves, private enterprise, and got a CON, but it cost a lot of money and a lot of time. And so that's another example of where we have CON has gone awry, and you have folks who have the operations not wanting to have competition. So we support the repeal. I would note that one of the other notes that the bill does have is that even without the repeal, the first section of the bill would allow single groups, not single specialty groups, but single groups like Harbin Clinic in Rome, South Coast in Savannah, there's a group called Privia, a very large group in Georgia today that would effectively allow those groups to build their own surgery center just for their own patients, just for their own group. So that's what the physician ownership language in the first section of the bill deals with. It takes it from a single specialty group, single group, to say if you're a multi-specialty group, you should have the right to have the exemption as well. So if nothing else, we support that part of the bill that will allow these big groups that effectively are iced out of, can't build their own surgery center because they can't get the exemption because they're multi-specialty. Again, they're cheaper, better quality, more convenient, and patients love them and insurers love them because they're more cost effective. So we support the bill, and anything you could do to make it more flexible in the state of Georgia, we would support. Thank you.
Thank you, sir. We'll call the committee's attention to the last page of the bill, since this was I know we've talked about delayed certificate of need repeal, and I guess the speaker just mentioned that, Mr. Moldovan mentioned 2 different things. If you look, there's really part 1 that would be in effect in January, parts 2 and 3, which are, I think you labeled the delayed repeal of CON.
And the licensing piece.
The licensing piece, and that would not begin until January of 2025, which I think addresses some of the committee's issues with knowing that we need to do something different, but wanting to take a little bit of time. Is that why you put that in there with the delayed start date?
It just gives people time to prepare and get ready. Make sure you're licensed properly.
Okay. Are there others who did not have a chance to speak earlier or who need to speak on this bill? Monty? Come on.
Thank you, Mr. Chairman and members of the committee. We come to you today on behalf of the Georgia Alliance of Community Hospitals, representing over 90 hospitals across the state, both rural, urban, and teaching. We come to you to oppose this bill. This bill would have a devastating effect on the healthcare delivery system in this state. We as a group oppose this because it comes when we should be thankful for our hospitals and proud of them for getting us through the crisis we've had with COVID and the crisis we're having with healthcare workers, especially nurses. This state is short about 30,000 nurses. We're paying traveling nurses over $150 an hour. This bill comes at the worst time for us. As across the state, hospitals are losing millions of dollars. Grady, for example, went from a 1.6 profit to over a 5% loss. Tiff General Hospital, a rural hospital in South Georgia, is losing millions of dollars per year. B.B. Putney, as I mentioned earlier, they're losing $12 million a month. This comes at the worst time possible because of rising healthcare workforce costs. When you repeal CON and allow ASCs to proliferate around the state, it just draws paying patients from the hospital. And if you do multi-specialty hospitals, it's sure to close many of our rural and maybe even some urban hospitals. We are ranked number 2 in the nation in terms of the numbers of ASCs we have in this state. Not-for-profit hospitals relies on bonds to finance capital projects. Under this bill, we would be limited in the dollar amount of reserves we could keep on hand. The only way to finance capital projects today is through bonds or getting a line of credit from your county. Because I represent the hospital authorities of the local counties as well as the not-for-profit hospitals. We're no different than the state. We have to have reserves in order to get bond financing. If we're to get our bonds insured where we can resell them, then we have to have reserves. Don't think the raters and underwriters do not look at this. They do. That's the problem with a lot of rural hospitals. They have no reserves, so they can't get bonds. The only thing they can do is rely on a letter of credit from their local government. The shortage that we're having in rural Georgia has nothing to do with CON. It's because we don't have the paying patients. We don't have the physicians. We don't have the nurses. And it's having a devastating impact on rural hospitals. I thank you for letting me come before you. I would like for Kathy Palvino to speak just a minute.
Just a moment, if you don't mind. I know you were mentioning the reserve requirement, and that currently, I believe in the bill is 12 months of
reserve
costs of operating costs.
Right.
Do you think that number should be higher? Are you saying you have more than 12 months of expenses?
We try to keep at least 180 days of cash on hand.
So 12 months wouldn't harm that. Is that
I
right?
don't think so. Especially at smaller hospitals.
So you don't mind the reserve requirement of nothing more than 12 months?
I think it should be just like the state. Whatever you can reserve, you can, because the rainy day comes. Like right now, the only way hospitals are surviving is on reserves. They're dipping into them at a rapid rate. We don't know when that time may come. God forbid we have another crisis like COVID. It's taking its toll on a lot of our hospitals. 43% of Georgia rural hospitals face closure within the next 5 years. 43%. Out of the 15 states that have repealed CON, most all of them have had to go back in and put moratoriums in place. Colorado, the governor was introducing legislation to put CON back in play because of the proliferation. And House, the Speaker of the House in Massachusetts just introduced legislation this year to stop the development of ambulatory surge centers because of the devastating impact it was having on hospitals. I hope that you will look at this carefully. We are 2 or 3 days from crossover. This bill needs study and a lot of study. And I don't mind working with the author if there are things he would like to see change, but to just radically make changes is not, that will not be what I think you would want as results. And it would change the healthcare delivery system in the state.
Do you like the portion of the bill that delays all that till 2025? Or do you want to not really want to change it then either?
No, I don't. I think there will be a trend when you see states that have repealed CON and going back and putting something in place to regulate the proliferation. I think Georgia can be a model. Should there be changes? We're amenable to that. Should it be shortened to legal oppositions? We're open to that. No one's come to us wanting to talk about CON until they introduce a bill.
Representative Fry.
Thank you, Mr. Chair. I'm just curious, y'all have any stats on states that have repealed CON and the failings of their health outcomes or their hospitals?
I'm gonna let Kathy address that.
Thank you,
She
sir.
has the list.
Thank you.
And unfortunately, there has not been comprehensive studies on some of these things. Some states have done, for example, Maryland do test cases where they, deregulate something for a few providers and study it and look to see not just the effects on patients, higher costs, but the effect on the Medicaid program, for example, of deregulating nursing homes. There's ripple down effects of that. But we do have some statistics on some of the states, for example, that have been mentioned. Texas, a state without CON, is #1 in the country with rural hospital closures. Texas has 81 more rural hospitals at risk of closing based upon their current status. That's, again, #1 in the country. Texas is the state predicted to have the worst physician shortages in the country by 2030. The cost of being hospitalized in Texas is $6,200 more than the cost in Georgia. The average charge for a complex COVID-19 hospitalization in California is $260,000 more than the average charge in Georgia. These are just some of the statistics that are out there publicly reported and available by entities such as Kaiser Healthcare Foundation, Becker's Hospital. There are studies out there looking at some of these effects, which is why we've said these things need to be studied because there is a ripple effect. Georgia's laws is also not there. The law, while we do have CON, through the changes both in 2008 and in 2019, we are a law of exceptions and exemptions. So many things are now approved. As Mr. Veazey mentioned, Georgia is #2 in the country, second only to Maryland, for number of ambulatory surgery centers per capita. And in terms of the numbers, it's significant. Non-CON states have an average of 1.96 ASCs per 100,000
Excuse me, could that
residents.
be partly due to our single specialty, that we only let one specialty at a time do one instead of letting a group like this bill attempts to do, letting several specialties for efficiency's sake, instead of building a 2-room surgery center for a single specialty? If you let a multi-specialty group, you might have many fewer. So it may be that that's a byproduct of CON and not necessarily a feature.
Well, one of the things we do see also, though, is that the physicians then take their business out of the hospital and hospitals are left struggling to provide coverage for the emergency department and other things. And so, again, there's ripple effects of lack of CON regulation. And in our state, because we do have all of these exemptions and exceptions, we have maintained lower charges across a number of specialties. We have the Medicare charge per inpatient discharge in Georgia.
I'm sorry, we're not going to be able to read Medicare charges and average. I'm sorry.
Sure.
Just we do have several questions for one of the two presenters, Chairman Houston.
Well, first of all, you mentioned California and the cost of medical care in California. The cost of living in California is a lot more than Georgia too. So, and I would, that might have a little bit to do with it. But are you pleased with the way the hospital, the healthcare delivery in this state has been doing? Do you think we need to make some changes?
I think there are a number of changes that need to be made in healthcare, and behavioral health is
I
one of
said
the
in Georgia, we did
Sure.
just passed a big behavioral health care.
We're
trying to do that.
Yes, and I understand the frustration with lack of changes in CON rules, for example. And one of the things that that House Bill 186 did in 2019 is it repurposed the technical advisory committees. And that enjoyed support of the hospital community and everyone to essentially look to modernize Georgia's CON rules. And that is always a process in which multiple people, physicians, hospitals, insurers work together on those committees. I mean, I've been around for a while. I was around when we had those committees, and they did result in changes to rules to address issues that could even be hospital replacements and what standards are in place for hospital replacements.
Did you say earlier that, I mean, I heard earlier, one of the speakers mentioned that Florida does not have the same CON restrictions that we have. Is that correct?
Yeah, they just passed it 2 years ago or a
And
year
Florida
ago.
does,
They
she
did.
said something about nursing homes, but I don't think Florida covers nursing homes, does it?
Florida does not. Florida covers hospice and various other services.
But not
So
hospitals
it's
and health
limited.
and ASCs and things.
I don't believe so. They
It
do have-
seems like their healthcare is pretty strong. It's attracting the elderly or anybody over 50 who may need healthcare. They seem to be doing a great job of modernizing facilities and attracting new residents who most need healthcare.
In South Georgia.
Yes, ma'am. Go ahead.
In South Georgia, Florida attracts a lot of people down to Jacksonville, Tallahassee, Gainesville. So a lot of people from South Georgia go to Florida for healthcare.
And what I would also say is that the hospitals here have made investments in their infrastructure and have made investments in technology. And those are things that the changes and some of the exemptions that have been put in place in 2019 have allowed. But with the technical advisory committees, they can look at more broad-based changes to the CON laws. And candidly, with COVID-19, there have been no technical advisory committees that have been put in place because the Department of Community Health has had other priorities, understandably, as
Chairman.
have the hospital community in terms of caring for patients during the pandemic. So, the lack of focus on updating the CON laws has been because of just obviously the priority of caring for patients during a
Well,
pandemic.
it looks like this is a renewed focus. Chairman Cooper.
May I don't, Monty, please.
Okay, Madam Chair.
Okay, rather deal with you than her. Okay, gets a little boring as she goes on. Okay, must be the lawyer that charges by the hour, minute, whatever.
Word.
Okay, so Monty, after the discussion, we're saying what a lot of us are saying is that we'd like to see sort of a different atmosphere when these questions comes up, that if there is someone sees and perceives a need for some changes, that maybe the hospitals, instead of just saying no, sit down and discuss it and see if we can come up with a solution. If it's a trial situation where we do allow a few hospitals to try it, that kind of participation, just instead of saying no all the time.
Well, I think several things you could do, one being streamline the process. We did that once before, and we could do it again.
And I still have the scars to prove how bad it was. Just
Well-
getting that. That's what I'm talking about. Just to get the hospitals to talk about it. It was a horrible, horrible process. The hospitals at that time, I think, hired 86 lobbyists to fight. I think on our side, if we could change, there were about 5 or 6 lobbyists.
I assure you, we do
Make the
not have
process so
86.
difficult. And there's always, despite the hospitals are going broke, there's always money to hire that many attorneys to fight it. It's amazing that they don't save money that way.
Well,
Thank you, Madam Chair.
if the government was not the number one payor, and if we got 100% on the dollar of our charges, then I think we would all fare better.
Representative Bentley.
Thank you, Mr. Chairman. I just want to say how much I respect everyone in this room, all of the hospital team that has worked really hard, taking care of all of Georgians. But I must say that this is my 10th year in the House of Representatives. And I've heard your words before. This is the worst time for this type of bill. In 10 years, I've heard that repeatedly. So just when would it ever be a better time, you think? I just think about how often I've heard those exact words that you stated, respectfully. But I have a question for you. Do you think the expansion of Medicaid would help in your concerns of the financial constraints these hospitals are facing at this time?
Yes, it would help.
Okay.
It would help rural hospitals, but we don't have it. And
Well, we can't
Yes,
debate
I just
expansion of
right.
Medicaid here.
Yeah, I'd
Certainly,
rather
But I just thought I'd ask the
everybody,
question. Thank you.
everybody knows that the guidelines on that, the fact that actually it
Right.
would change some of the people between 100 and 138% would get off of a United or a Blue Cross plan and would go on to Medicaid, which I believe you say is less than your cost of doing business, that Medicaid reimburses you less than
Medicaid
your cost.
reimbursement, we lose 17 cents on the
on
dollar
every
of our
one. So
charges.
we certainly don't want to change anybody from an Affordable Care Act anthem plan to a Medicaid plan if we can help it. But go ahead, Representative Fry.
Oh, I wait.
Oh, thank you. Chairman Knight,
I'm gonna make a motion.
quickly.
Thank you, Mr. Chairman.
I'd like
Yes,
to
sir.
wrap up discussion. Let's figure out what we're gonna do on this bill. And I actually would like to I've got a bill. I know that everybody's going home, but we've had a lot of discussion. And can we figure out what we're gonna do on this bill?
Do you have a motion?
I do this with a idea of, I'm getting blown up here, wife and everybody else. There's a lot of discussion.
Careful.
And I'm gonna move this, I'm gonna make a motion to move this on. But I do think that we need to look at it as it goes through the process. Let's call the question.
Is that a motion?
Yep.
We have a motion and a second to do pass.
That's right. Okay.
Do pass. Move it on. Is there other Chairman Parrish?
Where are we going to move it on to?
Rules.
Now, we're going to expect the rules to perfect the bill for us. Is that what we're doing?
I guess we'll do it.
You always have substitutes and rules.
That's not where we need to go, Mr. Chairman.
Do you have an alternate motion, sir?
Do you have an alternate motion, you said?
Yes, let's put this on the table with that other bill.
We have a motion and a second to table the bill before us, House Bill 1547, after vigorous debate. Any other discussion on this motion? If not, all in favor to table House Bill 1547, say aye.
Aye.
Any opposed? No. All right, we're going to have to, all in favor of tabling House Bill 1547, please raise your right hand. All opposed to tabling House Bill 1547, raise your right hand. This is opposed to tabling. All right, we're not going to table the bill. We have a motion and a second. No one. Well, Dean Smyrie, did you?
I was confused because I saw people voting both ways.
The motion, the motion on the before us right
I
now
saw
is
people
to
voting.
table.
Can you vote both ways?
That's only at the polls.
Some of my friends are for it, some are against it. I'm from my friends.
Can you hear me, Mr. Chairman?
Yes, sir.
Hear me?
No voting both ways, sir.
Huh?
There was a motion to table the bill and it failed. Now the motion is to pass the bill. A motion and a second. Is there further discussion on House Bill 1547? All right, all in favor of do pass House Bill 1547, LC 339072, raise your right hand.
Do I get to vote?
Yes, sir, you're on the committee. Seven, all opposed. Dean Smyrie, did you vote?
Yes, I'm voting no.
Okay. The bill passes. We will quickly move on to a bill we've had to add to the agenda. If we can do it in 10 minutes.
All right.
Chairman Knight, this is House Bill 1519.
1519. First of all, Mr. Chairman, and everybody in the audience, I'm not sure I've seen as much passion,
Hey, Robbie.
as much anger,
Yeah, okay.
frustration as I've seen today over healthcare. And I can tell you that I think a lot of people generally are concerned about healthcare and about the patient. And I hope that we can start to look at these things in more detail. And I think that 1519 is probably one way to start a discussion whether this bill proceeds today or not. This community, this state, my community and many areas around the state have seen what over the years? We've seen in the middle of plans, healthcare plan years, we've seen all of a sudden, what did you get a call? You got a call that your plan was no longer, you're no longer in the network, or your hospital, or your physician is no longer in network. And this is mid-year. And what 1519 seeks to do is seeks to, if you will, look at these services, these ancillary services, and some of the practices that are going on and define those. But what's happening is all of a sudden midstream, you're having unilateral decisions being made by the insurance companies to all of a sudden change the terms of the reimbursements. Unilateral. I played sports all my life. Many of you play sports all your life. And you once the whistle blew, whether it's on the basketball court or whether it was on the football field, you knew when you went on that field from the second the game started until the last second of the game, you knew what the rules were. And both sides played by the same rules. But apparently what we're seeing all over Georgia, whether it's in our state health benefit plan, whether it's in commercial plans, we're seeing right in the middle of the game, unilaterally, one side changes the rules. And I'll tell you who is hurting the patients. What this bill seeks to do is to define these ancillary services, and I'll get to this of what really is happening here. But basically the bill says that once you start this, you can't make these unilateral amendments to the contract. Okay? Because I'm telling you, I don't know how many calls I got months ago, and I think they're still out of network with my hospital, where state health benefit plan, folks were out of network. No fault to the patient. Guess what? Unilateral amendments by the insurance companies come in and say, hey, we're going to demand lower prices. But that wasn't what the beginning contract was. So what this bill seeks to do is to stop that. It's sort of interesting as it dovetails into what these services, ancillary services are. These are things such as white bagging. How many of our rural hospitals and other hospitals have been dealing with white bagging? Huh?
Go and explain what it means.
White bagging. And there's, I've actually got a few of these. I don't know if I've got enough to pass out, but white bagging, there's some, okay, pass those down. Pass those down. Okay. White bagging is where physicians to order drugs from specialty pharmacies that are contracted with the health plans. This pharmacy mixes, fills, and labels the drug. No changes are allowed to the dosage after the drug is filled and labeled. The drug is then transported outside of the pharmacy's ability to ensure the quality and oversee the chain of custody. It could be delayed, damaged, contaminated, counterfeit shipments. And then the physician runs the patient's labs at the end of the day to confirm its treatment is safe or effective, and if changes are needed. In other words, what this is doing is it's basically, you can't even go, the pharmacy, the big insurance companies are demanding they're going to say, you got to go outside. We're going to mix these drugs and we'll send it to a hospital or to an infusion area. Okay. Dr. Newton, is that safe? Do you trust that?
I think I know a pharmacist or two who would say that, and a nurse or two who would say injecting a medicine that somebody just handed you into a patient's IV without the certification that a hospital, a healthcare center does would be.
But that's
worrisome.
one of the examples.
I don't want to be the receiver.
Yeah. I mean, think about cancer where it's mixed that day that a patient comes in, or infusion treatment. But it's not only that, it's ancillary services. It's things that we hear. It's lab, it's in the lab space. It's in the imaging. It's in a whole host of other ancillary services. And so all of a sudden, a lot of these contracts are being, hey, you got to take lesser charges, or, hey, we're going to send these services out to another vendor. Lo and behold, in looking at this, started figuring out there's another player that's in here that, quite frankly, I haven't heard in the room. That's the insurance companies. And I started looking at some of the wholly owned subsidiaries, and I'll give you an example. There's affiliated physicians practices and other practices such as, it should be sleep, pain management, all these, that guess who's getting into the healthcare space? It's the health insurance companies. There's one that's a wholly owned subsidiary, Anthem Blue Cross Blue Shield. This is a group, Pasteur Medical out of Florida. What do? Ancillary services, x-rays, in-house pharmacies, dental, ophthalmology, physical therapy, pain modalities, laboratory collections, x-rays, you name it. So guess what? What we've started to see and we've seen over on the pharmacy benefit side, guess what? Is happening right now in the healthcare world. And we start to look at why these contracts in the middle, well, guess what? It seems like there's some steering. Here's Optum. Here's a sheet, pass that down. We only have a few of them. We're good. Here's all of the physician, the healthcare services that the insurance companies are starting to get into, and they're starting to own. These are wholly owned subsidiaries of the insurance companies. But yet, aren't the insurance companies designing the plan? Aren't they the same ones that are entering into these contracts at the beginning of the year, but midstream, somehow they're changing and demanding, oh, we need better rates. Why? I guess they're trying to push over to their healthcare downstream assets. Guys, we've got a big problem. We've had this over the last number of years. We've seen it in North Georgia. We've seen it in Atlanta. We've, recently in Spalding County. This bill seeks to at least define what these ancillary procedures are, and it seeks to make sure that the insurance companies cannot come in midstream and change the contract unilaterally. Okay? At least both sides need to agree. I'm not sure with 10 minutes, we can continue to talk about all the details of this bill, but I think it's
pretty short bill.
interesting in the discussion that we've had that some of these businesses and some of these things that are popping up are insurance company owned assets, practices, lab space, lab companies, or X-ray, imaging. And I'd be curious to know what this is and how that is taking an effect on our healthcare in Georgia. But that's what this bill seeks to do. Mr. Chairman, not a
Thank
lot
you.
of time,
I
but
appreciate you being as brief as possible. I would point out, I guess, in line 43 and 44, this only applies during a contract, as you say, a midstream change to a contract, similar to what this committee did last year on House Bill 454 that said during a plan year or during a pandemic that an insurer couldn't throw a healthcare system or provider out of network. And I think that's helped some people in the greater Atlanta area recently. Chairman Parrish. Oh, I'm sorry.
Perkle.
Yes, sir.
You just had a compliment, my friend, or I did one.
All right. I didn't know. what
Thank you,
button
Mr.
it was.
Chairman. To the author, a quick question. I don't doubt that there are problems, there are issues. It bothers me no end, a unilateral, almost a bait and switch, and we should seek to find ways that we can stop that. A concern that I have, and I know very little about this particular subject, but and I can't call the name of the company because it has escaped my memory. But I think there was a laboratory service company that either portended or pretended to provide services that it turns out was not accurate. It's not based in science. And I don't see anything in your bill that would allow an insurance provider to say to cancel a contract for a service that is either doing shoddy work or is inventing the results, or if there were significant problems in the testing criteria for the lab.
and that is a great question. It's one that I actually asked. In other words, concern would be such that a vendor did something that was unlawful or that invalidated a contract. I mean, for a bad act. Okay. I think this does contemplate this. May want to look at language to strengthen it, but in 55 going down, it talks about required by law and applicable regulatory authority and so on. And so and again, the impetus of this bill is not to undo the contract itself and terms in the contract, such as making sure that you're providing a valid service. And, it's indeed not somebody's not doing something that would have a justifiable cause to, in this case, just probably, kick them out of network for a cause. That's not what we're trying to do here. We're simply, those are terms of the contract. We're just simply, when it comes to time in the middle, that you can't make a unilateral amendment to a contract that two parties signed at the beginning of the year. So we're not trying, and if there's language that we could do to clarify that this is not meant to get into the area of a cause for, leaving or being kicked out of the network
for cause termination, that this doesn't look like it affects, and also the applicable regulatory authority on line 57, as you mentioned, really would take care of any that did not meet the laboratory standards, for example, or pharmaceutical standards. I guess we did have a handout on the pharmacy ordering channels regarding the hospitals and the white bagging. That could be, you're saying that actually goes on?
That's a current practice right now.
And so that would be, so anything that had some profit built in it, they could do it to their own subsidiary and leave the hospital with all the loss leader portions of healthcare.
Yes,
and
absolutely.
Okay. And you're seeking to.
Well, and you're seeing this in
Stop
lab
that.
space, you're seeing this in imaging. So, you know, again, when we start to look at this stuff, let's look at who all is a player there. And again, I think we're going to end up seeing similar to what we've seen on the pharmacy benefit side, examining downstream assets of the very insurance plans to see if, again, there's steering or there's a conflict of interest. In other words, that insurance company may have a financial interest or an ownership interest in a downstream healthcare provider or imaging lab. Okay. No wonder these contracts, they're taken when it's unilateral, you got a problem. A unilateral amendment.
Were there, Chairman Cooper?
I just, appropriate time, I'd like to make a motion of do pass.
We have a motion and a second.
And one amendment, if I could, and there's something I left
It's the
out of
appropriate
Bill.
time for an
All
amendment.
right, there's an amendment, and what this does is it simply adds, and I got a copy for the chairman, I'll read it. On line 15, after the word services comment, we put in infusion services. Okay.
To be sure that in addition to pharmacy services, that infusion services
Yeah.
are also, so it's a two-word addition, is that correct?
Yes.
On
And so-
line 15,
Yep.
after pharmacy services, it would say, also say infusion services, and then go on with radiology and other diagnostic tests. So that's,
I'll make a motion.
yes, all right, we have a motion
that we
and
include that.
on the amendment and a second on the amendment for HB 1519 of the two words infusion services on line 15. Is there any other discussion? If you're in favor of the amendment, say aye.
Aye.
Any opposed, say no. All right, the amendment passes. Now we do have a motion and a second on House Bill 1519 as amended. LC 520112 as amended. We have a motion and a second. All in favor of passage of the bill, say aye.
Aye.
All opposed, no. The bill passes. Thank you all for your
Thank you.
patience today and for your participation and working together with us for great healthcare. Thank you.